All right, so this is just brief pathology, the majority of which you should already know and be coming into class with. So fluid and electrolytes are fundamental to maintaining homeostasis, crucial for life. It's a dynamic process. And so when our fluids and electrolytes, whenever one or both are off, it can be detrimental to life. This is a breakdown of what the total body water composition is in the body. So we have about 40% body weight is intracellular, which means inside the cell, intracellular. And then we have extracellular, which makes up about 20% of the body weight. And that would be your interstitial, your plasma, and your transcellular. Transcellular is like your spinal fluid. And then plasma, like lymph fluid, is interstitial fluid, and the interstitial space is the space that's between the cells, tissues, organs, and blood vessels. It's not a good idea to try to lose weight by not drinking water. Please drink your water. Third spacing is a very important concept to really get. Third spacing is basically when the fluid in your vascular space, your arteries and your veins, when that is going into your interstitial space. So your body thinks that you are having a fluid volume deficit, when in actuality your body is overloaded because all your fluid goes into the interstitial space. So you're going to be swollen. You're going to have an increased heart rate, decreased blood pressure. You're going to have a CVP that's decreased. CVP stands for central venous pressure, which is the right atrial pressure, and you'll learn more about it in critical care. And you're going to have an imbalance in your eyes and nose. The beginning signs of this third spacing is the patient will have a decreased urine output, although their intake is adequate. So the minimal urine that you are supposed to put out is 30 mLs per hour. So the body is supposed to make 30 mLs of urine an hour. Basically, remember your body is having symptoms of fluid volume deficit because in the intravascular it does not have the fluid. The fluid is in the interstitial. So your body is unable to access that fluid. And this occurs in burns, ascites, peritonitis, bowel obstruction, and massive bleeding into a joint or cavity. So knowledge that you should be bringing also are what electrolytes are, which are active chemicals that carry positive or negative charges. They're always measured in milliequivalent per liter. We have major cations and anions. The major extracellular cation is sodium, and the major intracellular cation is potassium. For anions, which is your negative charge, the major extracellular is chloride, and then the major intracellular are your phosphates and your sulfates. If you choose to look at page 55, table 4.1 has approximations for what major electrolyte content in body fluids should be. All right, so this is a picture of capillary dynamics. It's kind of an important concept to understand, so if you do not understand it, let's try to break it down for you. Your fluid movement is dependent on two forces, and these are called Starling forces for those of you that like Jeopardy. You have your capillary hydrostatic pressure, which is going out, and then you have osmotic pressure, which is going in. And the capillary bed is actually called oncotic pressure, which is just a type of osmotic pressure, so don't get confused with that. At the top here it just has blood flow, and that's your that's your arterial side. And basically your pressure is going to be higher on your arterial side. And then down here at the bottom is your venous side, where pressure is lower. So the hydrostatic pressure is going to be generated every time the heart beats. And it exerts on the walls of the blood vessel. So that's the arterial side pressure, which is higher. And because that pressure is higher, it's going to exceed your oncotic pressure and go out into your interstitial space. So hydrostatic pressure is a pressure that is generated by fluid on the walls of the capillary, and it forces water out of the circulatory system. And then your oncotic pressure is a form of osmotic pressure that is exerted by proteins in a fluid that usually tends to pull water into the circulatory system. Pressure is higher on the arterial side and lower on the venous side. So let's think of maybe an example we can translate into real world. So say you have a patient whose blood work shows that they are protein deficient. Well, if they are protein deficient, then they're not able to pull fluid into the capillary by oncotic pressure, because you need proteins to be able to do that. So they are going to start third spacing. So you're not going to be able to pull your fluid into the capillary. So it's going to start building up in the interstitial space. And then that means that you're going to start having third spacing and edema. If you have too much protein in your blood, you could pull too much fluid into your capillary, and then you could have fluid volume excess. Alright, so this is a video on osmosis and tonicity, which I think is very good. So let's watch it. Maybe we'll watch it. Where's my little red thing so I can push play? There we go.
Before we take a look at how osmosis and tonicity affect the cell, let's review what each of these terms means. Osmosis represents the diffusion of water across a semi-permeable membrane. The term tonicity refers to the relative solute concentration of two environments separated by a semi-permeable membrane. In other words, by comparing the tonicity of the solutions, you can determine the direction in which osmosis will occur. To demonstrate how tonicity affects a cell, let's place some red blood cells into a beaker containing pure water. In this case, the solute concentration is greater inside the cells than in the surrounding water. In other words, the contents of the cells are hypertonic in relation to the hypotonic contents of the beaker. Because of this, osmotic pressure results in the diffusion of water across the membrane and into the cells. Over time, if enough water enters the cells, the cell membranes may burst. This is called lysis. Now let's place the red blood cells in a beaker containing a solution of salt, such as sodium chloride. Since the contents of the beaker are hypertonic in relation to the interior of the cells, the water within the cells will diffuse across the membrane and into the contents of the beaker. This causes crenation, or shrinking of the cells. If the red blood cells are placed in a beaker whose contents match the tonicity within the cells, then there is no net gain or loss of water. The environments within the beaker and inside the cells are said to be isotonic, or the same. An important thing to remember is that osmotic pressure always causes water to move from a hypotonic environment toward a hypertonic environment. In other words, water moves toward areas of high salt or sugar concentrations. This simple process is used to drive the operation of our kidneys and explains some of the physiological consequences of diseases such as diabetes.
remember that statement, water moves toward a high salt or sugar concentration. So if you're spilling sugar into your urine, you might have high sugar in your blood. If you're eating a high salt diet, you're going to retain a lot of fluid because water follows salt. All right, let's talk about osmosis and diffusion. Please remember that osmosis is the process of fluid moving from low concentration, so your high solute concentration, low fluid concentration, and high osmotic pressure. So your fluid is moving to an area of higher solutes. So if you see that this is like half water, like it's half water compared to the left-hand side, and there's like a high concentration of solutes. The fluid is going to move from the left side to the right side to try to even that out. That's basically osmosis. And then in diffusion, we have the movement of fluid. So we have an osmotic movement of fluid from this low concentration of solutes to this high concentration of solutes, but we also have solutes moving from this high concentration to this low concentration. So you have both moving. So if you have a diet, so you've just eaten, and your belly is full of food. The process of fluid moving into your belly is osmosis because it's just the movement of fluid. But, okay, so now you're digesting your food and it's in your intestinal tract. That is going to be the process of diffusion because you have fluid moving into your intestinal tract and you have solutes moving out of your intestinal tract. I hope that makes sense. If not, please come see me. All right, so how do we regulate body fluid compartments? Well, there's this thing called osmotic diuresis, and it's an increase in urine output that's caused by the excretion of substances. So if you are excreting sugar in your urine, you're going to have an increase in urine output, so you're osmotically diuresing. People who have had head injuries, we give them mannitol, which is an osmotic diuretic to help them urinate more so that the ICP in their brain goes down. So osmotic diuresis will increase their urine output, which causes an excretion of substances, and it exerts an osmotic pull on water. Basically, when glucose is spilled in the urine, it takes water with it. This causes excessive urination. That should be fluid volume deficit. Yes, fluid volume deficit, because you're excessively urinating, so you are having a deficit in your body. We've talked about osmosis, and we've talked about tonicity. Another thing I want to say about tonicity, when we're talking about fluids, a student told me one time, so isotonic is there's nothing changing at the cellular level. You're going in, you're going out, you're good. Hypotonic is you are making the red blood cell get bigger. So think of hypo like hippo. It's larger, it's bigger. Examples of hypotonic fluid, half normal saline is a hypotonic fluid. And then hypertonic fluid, you're making the red blood cell cremate. You're making it smaller. So think of hyper as skinny, because when you're hyperactive, you're running around, you're burning off a lot of energy, and you're skinny. An example of a hypertonic fluid is D5 half normal saline. Hope that helps. Okay, so we talked about diffusion and now filtration. So we have a bunch of different filters in the body. We have the lungs, which are a filter, the liver, which is a filter, and we have the kidneys, which are a filter. So in the kidneys, we have this hydrostatic pressure, which I talked about earlier, and it filters fluid out of the intravascular into the interstitial. So we have water and solutes from an area of high hydrostatic pressure to an area of low hydrostatic pressure. And this allows our kidneys to filter up to 180 liters of plasma per day. And then we have the sodium-potassium pump. And the sodium-potassium pump is along so we have the sodium-potassium pump, which is basically in like every cell of our body. And the way it works is by active transport. So the way to basically, like, all you really need to know, if I can draw a picture here. So you have, I wanted to draw. Oh, there it is. All right, so you are on a boat. You're on a boat. And the boat has, you're on this ocean. And ocean is filled with fish. And you are fishing with your little hole here. So you are actively trying to get fish into your boat. But your boat has a hole and it's letting salt water in. So you're trying to get the fish in, that's potassium, because fish are high in potassium, and you're trying to get your salt water out. So that, in a nutshell, is active transport and how the sodium-potassium pump works. I apologize for my drawing. I'm trying to work this thing out. All right, then we have routes of gains and losses. They're pretty simplistic. We have PO, right? If you're healthy, you eat, you drink. You can have parenteral, which is IV, enteral, which is like a peg tube feeding. You have your kidneys, lungs, and your GI tract. So you lose through those things. We then have serum osmolality and urine osmolality. So serum osmolality, the number that to remember is 275 to 300 milliosmol per kilogram, and with urine it is 250 to 900. It's much wider. So we have osmolality and we have osmolarity. Please do not confuse yourself. They are almost the exact same thing. They just are measuring slightly different things. So with osmolality, it's the concentration of fluid that affects the movement of water between fluid compartments by osmosis. And with osmolarity, it is just the concentration of solutions. Things that can cause your osmolality to increase, your serum osmolality to increase, are things like dehydration, diabetes insipidus, high sodium, high sugar, a head injury, renal tubular necrosis, and antifreeze consumption. So basically your serum osmolality will increase because it's anything that's going to make the solute concentration higher than the fluid concentration. So you have the capillary here, if I can get my thing to draw. You have your capillary here, so that's your vein, and then you have all these things in here. These are all your solutes. So you have all these solutes and you don't have any volume. And that's why your serum osmolality is going to increase. So things that are going to make your serum osmolality decrease are things that are going to increase your volume. So fluid volume excess makes it decrease. Syndrome of inappropriate antidiuretic hormone is going to make it decrease. And we will talk about SIADH when we talk about endocrine. Kidney failure, diuretic use, all these things are going to make your volume increase, which will cause your osmolality to decrease. And then with urine, it's like the opposite of that. So if you have a fluid volume deficit, you're not going to have a lot of urine, and that's going to make your urine osmolality increase. If you have congestive heart failure, you aren't going to have a lot of urine because it's retained. It's like you are like fluid overloaded because of congestive heart failure. So you are not going to have a lot of urine, and it's going to cause your urine osmolality to increase. And then things that would make your urine osmolality decrease are like anything that makes you pee a lot, basically. So fluid volume excess, diabetes insipidus, pyelonephritis. So it's kind of the opposite. All right, then we can also use certain laboratory tests to help with evaluating our fluid status. So our urine-specific gravity is the measure of the kidney's ability to excrete or conserve water. It has an inverse relationship with volume. So the more volume you have, the lower your specific gravity is going to be, and the less volume you have, the higher your specific gravity is going to be. It is a less reliable indicator of concentration than urine osmolality because of the fact that it is influenced by the number and size of the particles in the urine. So if you have a lot of sugar or a lot of protein in your urine, you can get a falsely elevated specific gravity even if your volume isn't really less. So BUN, or blood urea nitrogen, is a metabolic test. It measures the metabolism of protein. So it's an end product of this metabolism. And BUN is, with the creatinine, is a good indicator of your kidneys, but it's not the best indicator of your kidneys because of the fact that so many things can influence your BUN. So your BUN can be increased because of decreased kidney function, but it also can get increased because you're dehydrated, or a patient has GI bleeding, or they may be eating more protein in their diet, or they have sepsis. Things that can decrease a BUN are like end-stage liver disease, a low-protein diet, starvation, SIADH, and pregnancy. Basically any condition that results in expanded fluid volume. Now your creatinine, that is your best indicator of kidney function because it does not vary with protein intake or metabolic state. It only increases when your urine function decreases. So creatinine is your best indicator. You also can have hematocrit changes. So the more dehydrated a person is, the less volume they have, the higher their hematocrit is. Hematocrit will measure the volume of red blood cells in whole blood. And conditions that increase your hematocrit are dehydration, polycythemia can increase it because it makes the blood viscous. And conditions that decrease it are, of course, anemia and overhydration. And then we have urine sodium. So that changes with the amount of sodium taken in fluid volume status, and our normal is 75 to 200. So urine sodium is important in helping to assess volume status and diagnosing hyponatremia and acute kidney failure. We already talked about that. And then we have homeostatic mechanisms in the body. Our kidneys, they help to maintain fluid and electrolyte balance by filtering. Our heart and blood vessels, they help. It helps because of the fact that it circulates blood through the kidneys so that the kidneys are able to filter. The lungs are vital because of the fact that we excrete CO2 and take in oxygen. So your adrenal gland and your pituitary gland are very important, and when we get to diabetes, or endocrine rather, Ms. Poindexter will actually talk more in depth about it. And then we have baroreceptors, we have the renin-angiotensin-aldosterone system. Please, you have to know the renin-angiotensin-aldosterone system. There's just no getting around it. It's very important in blood pressure management. So just to recap what happens, your kidneys, they, like in a normal person, the blood pressure is low, so it releases renin, which goes to your liver, converts to angiotensin 1, which goes to your heart, and converts to angiotensin 2, which goes to your adrenals, and you release aldosterone. And then aldosterone is going to hold your water and make your blood pressure go up. The antidiuretic hormone in thirst, which Ms. Poindexter is going to talk about ADH when she talks about endocrine. And then we have osmoreceptors and the atrial natriuretic peptide. Some gerontological considerations. We have reduced cardiac, renal, and respiratory function in reserve because of the fact that we're elderly. We're going to have alterations in our body fluid to muscle mass. We're going to have less muscle mass, so we're going to have alterations in how much body fluid we have. Older people are frequently on medicines that affect the heart and kidneys, which will alter their fluid and electrolyte balance. Older people tend to present subtly or atypically, so the changes are not seen right away. And dehydration is very common in the older population because of the fact that they have less subcutaneous tissue, which makes it harder to hold fluid in. All right, so yeah. Next we're going to talk about fluids and electrolytes, but you need to watch this video first because it's a good patho review, and you need that because I'm not talking about it Friday. All right, thank you. Bye.